Hi, I'm Bob Harrington from Stanford University here on the Heart.org radio. It's been an interesting fall with regard to medical meetings. We had a fantastic meeting in San Francisco with the 25th anniversary of the TCT meeting, and then off to Dallas for the scientific sessions of the American Heart Association. And going back and forth at sessions and discussions and presentations at those two meetings, it's caused me to reflect a little bit on the future of medical meetings. Interestingly, in Science, early in October, they dedicated the issue to medical communications and medical publication. And largely, while they focused on the notion of open data, open access, they included an article on the medical meeting. And they didn't come down on the side that I thought they might, which is information is now available on the web. You can get it real time anywhere in the globe. Why would you go to a meeting? No, they didn't say that. Instead, they said nothing replaces seeing a colleague's face presenting some data or telling you about a latest discovery. Nothing replaces seeing a young person present his or her science for the first time. And it's that human element that we all seek out when we attend one of these conferences. So as I reflected on that, I thought it would be interesting and perhaps useful to have a conversation with somebody who really is one of the world's leading experts in medical education, in particular the large meeting of medical education, and that's Dr. Gregg Stone. Gregg is a professor of medicine at Columbia. He is the co-director of medical research and education for the Cardiovascular Research Foundation, CRF, both in New York City. Gregg has been the longtime leader of the TCT meeting and is a tremendous thinker and innovator in the world of medical education. So, Gregg, thank you for joining me here this morning on the Heart.org radio.
Hi, Bob. Great to be here.
Well, Gregg, now that you've semi-recovered probably from putting on the 25th anniversary of the TCT, I'm wondering if you can maybe give our listeners the broad view. What has that 25-year horizon of thinking about the TCT to now having, the world's largest interventional cardiology meeting year after year? What's that trajectory been like? And then we'll get into where you think it's going.
Well, Bob, it's been really an extraordinary ride from the first TCT 25 years ago, which was held in the basement of the Omni Shoreham Hotel in Washington, D.C., and was really, a group of around 200 people who were just kind of looking for new innovative technologies to get excited about. It wasn't really about standard of care. It was kind of more about the future. To the meeting growing over the years, to trying and to some extent be all things to all people, and not only in the United States but around the world. And that is, TCT really has focused on, of course, live cases, which are the heart and soul of the meeting, how to actually do angioplasty in both simple and complex procedures. It has spread from first the coronary arteries to the entire vascular tree, and now to multi-structural heart disease intervention, and it continues to spread with the areas that interventional approaches are capable of managing. And the audience has grown in terms of global distribution, such that now about 70% of the physicians that come to TCT are from outside the United States. So we have to think not just of the needs for the United States physician, but equally to Europe and Asia and South America, Latin America, the Middle East, etc., to continue to figure out ways to present late-breaking science, both in terms of oral and poster abstracts, as well as an increasing number of late-breaking trials. Of course, cardiology in general and interventional cardiology specifically is just blessed by the number of randomized trials and large-scale, high-quality observational registries that are performed. There's so much knowledge to be able to disseminate and transmit. And how to do this in a reasonable time frame, in a way which will optimize or maximize the participants' take-home of knowledge so they actually retain it, to make this cost-effective because of increasing costs and time that it requires for people to be away from their practices, and to mix this all into a pot and come out with something each year that is different and stimulating and provocative and worthwhile for somebody to take that much time away from family and occupation is really a challenge. And we work year-round on looking very carefully at the needs of the physician and allied healthcare community to be able to, radically change TCT pretty much every year to some extent to try to meet those needs.
Yeah, it's really a remarkable meeting. There's a couple things that I'm thinking about as you gave your opening here. One of which is the global nature of the meeting with 70% non-U.S. attendees. That really does change the game in terms of how you think about education. But you said something else that I want to maybe start with, Greg. You said, be all things to all people. I'm struck over the years at TCT that as the field has evolved, the meeting has evolved so much that I was walking out of the TCT Speaker Ready room a couple weeks ago, and I bump into two of my non-interventional colleagues from Duke. And I said, wow, times have really changed. It used to be that the Speaker Ready room at TCT was really interventional cardiologists. But now it's everybody, Greg. How are you managing? Why are you doing all that first? And then secondly, how are you managing all of that?
Well, I think it really reflects, Bob, that interventional cardiology is not on an island. To be an effective interventional cardiologist, you also have to know pharmacology, you have to know heart failure, you have to know renal disease, endocrinology, you have to be able to relate with internists, family practitioners, general cardiologists, you have to know imaging, which has just exploded in importance, you have to be able to work closely with your surgeons to be able to make the right treatment decisions. And I also think that all those other subspecialties, if you will, also recognize that to give the best care to their patients, they also have to understand interventional cardiology. So there has become an intermingling of the subspecialties where we're not just interventional cardiology anymore, but we have a fair number of surgeons, radiologists, peripheral vascular specialists, vascular medicine specialists, internists, general cardiologists, surgeons, and of course then industry, press, media, all the other people that are required to continue advancements in medicine. And so we do try to appeal and provide content that's important for all of those different stakeholders, if you will. Some of it on a very simple level. We've got some courses that are called the ABCs of Interventional Cardiology. We have a nurse and technologist symposium that's been going on for more than 20 years, to, of course, the more garden variety, basic and complex interventional cardiology, to the late-breaking science and future innovative new concepts that are very device and very specific for this audience. So it really is a challenge, but it's something that we embrace, and it requires more than just a few people, but a large group of physicians both at Columbia and CRF that do this all year, along with associate directors. We have a list of more than 50 from around the world who help us in this venture.
Yeah, it's really incredible, and reflecting upon my own time helping put on the American Heart Association meeting, you're absolutely right. I mean, our program committee is approximately 70 people representing all sorts of groups of stakeholders from around the world, and it really does take this enormous effort. One thing I think you've done superbly well, and I hadn't quite realized it was more than 20 years that you've done the nurse and technologist track. You guys really embraced the team approach to interventional cardiology and then the broader area of cardiology care far before anybody else did, and so kudos for that.
Well, thank you. I like to think we were ahead of our time, and perhaps in some ways we were, but it's great to see now that this heart team concept, also taking into account patient preferences, really finally hitting its stride, I would say, in its terms into how we make treatment decisions for patients.
Yeah, no, I absolutely agree with you. This notion of patient-centeredness is appropriately right in the middle of everything we're thinking about now, whether it's interpretation of clinical trials, making therapeutic decisions, et cetera. Gregg, let's move to sort of where things are going. And one of the novel aspects of TCT this year that certainly I had a lot of fun with was the tablets that you gave out at the meeting. I'm wondering if you could share with the audience, how did that come to be, and what did you learn now that you've had a few weeks to reflect upon how people use the tablets?
Right. Well, so for many years, Bob, we've kind of agonized over kind of two big issues that we wanted to try to figure out how to improve upon. And that is, number one, that many of the participants at a meeting the size of TCT, and you're talking 10, 12,000 plus people, are really passive audience members. The rooms are large. Sometimes there aren't even mics in the large rooms. There's not sufficient time for discussion. They just sit there, and you've got a dais of people that are basically giving lecture after lecture, and there may be some short discussions, but there's, again, the audience members are just sitting there kind of passively receiving this information. And we've been trying to increase the amount of discussion that we have in the rooms over the years, and we have done so, but again, many people are shy and don't want to have discussions, won't come up to a microphone. So we've tried with the concept that the more interactive the meeting can be and the more that the participants are actually involved in the meeting, number one, the more they'll enjoy it, and number two, the more they'll feel that, the more they'll be able to retain information once they've left. So that's kind of been issue number one. Issue number two is how to take from TCT, which is a 5 to 6 day meeting. It's a long time when you think about that. It's almost a week a year. But how to, expand that experience beyond the walls of the meeting so it's really year-long learning. So what we came up with, at least for number one, is the concept of using, the digital revolution that we're all taking part of. I mean, our one indispensable adjunct that we go to bed with, we wake up with, is our smartphones right now. We all have iPads. We're all so linked to our computers, et cetera, is to figure out how to use that technology to be able to bring the audience member to become more of an integral part of the meeting. And so we basically sat down one day. We actually spent about 8 hours on just blue sky ideas. For the last 3 to 4 years, most major meetings, including TCT, have had an app, but it's really been nothing more than just kind of a listing of what's going on at the meeting and perhaps what rooms they're in. And we said, let's throw all that out and let's come up with, 24 ideas as to how we can use this technology to be able to make people feel like they are more part of the meeting. And we came up with a lot of amazing ideas, actually, from the basic things like making a much more interactive program where people can search by topic, by keyword, organize their calendars, et cetera. But what we're more excited about are the innovations such as the digital chat rooms, where in most of the sessions we have a digital moderator and a digital chat room, which is created where the digital moderator would be addressing the audience and answering questions from the audience about topics that are usually related to the talks or the live cases being given, or may not have even been related. And I think this was something totally novel that no one had seen before and was pretty exciting to most people once they got used to it. And in fact, in the large theaters, the ones where we actually transmit live cases, we actually transmitted that stream of comments onto a large screen. And so,
I found myself getting distracted by that.
Yes. Well, and that's one of the challenges, actually, because, some people, they can't listen to a lecture for more than 5 minutes before starting to zone out, and they like to multitask. And for them, it might be perfect, and they might like to actually focus on one comment and go deeper on it rather than just having a 30-second slide, where other people might find it distracting. And that's the nice thing about it, is nobody's forcing anyone to use this. It's a resource that's there if you want to use it. If you want to just sit there and listen to the lecture, that's fine too. The tablet had a built-in audience response system. The tablet had ways to view live cases. live as they were occurring, so you didn't have to be in the room anymore to actually see the live cases. And I must say, the HD quality and the audio surpassed our expectations of the live case transmissions. I don't know if you looked at them, but it was pretty remarkable.
I did. I was really enjoying. I said it sort of, smiling when I said I was distracted. It was an enjoyable distraction. I was sitting on stage moderating a session, and I found myself drawn into the chat room to start answering questions and sending thoughts out. And my co-moderator tapped me and said, "Hey, we got a digital moderator for that. Pay attention."
Oh, it's so funny. And, we had a way through the app to download all the slides of the conference. So anyone who came to the conference had full access to all the slides that could be downloaded. They could view, again, the late-breaking trial sessions live or archived, and multiple sessions were all archived within the app itself. You get your CME within the app. You would plan your dinners within the app. We also had a communication system where all 12,000 plus people at the meeting you could communicate directly to in a identity protected fashion in the app. So if you wanted to contact anyone, whether they were faculty or just an audience member, and you knew their name, they were in the app, and you could write them either an email or an SMS text, which would appear within the app. And that's just kind of scratching the surface of what we were able to develop.
So, again, compliments, because I enjoyed it. I think it did elevate the meeting experience. And as we close, Gregg, so we reflected upon the past, the present. Let's just think for a moment where the meeting is going. For at least 10 years now, as the Internet has become more and more ubiquitous, people have said, well, the live meeting is going to die. I've never believed that, because I think that there is a role. They have to change, but there's a role for the connectivity that only happens face-to-face. What's your view? Do you believe that the live meeting will continue, albeit differently?
Well, we've been worried about that as well. And we've seen, as you know, a lot of the large multi-specialty meetings have been decreasing in attendance over the years. And, again, this is more expensive. It's more difficult to get away from practice. Industry, which is responsible for transporting many people to meetings that are outside the United States, are having more economic difficulties doing that. And so we've worried about this to the extent that we've actually figured out ways that we could run virtual meetings on the Internet. We've come up with software where we can have you walk into a convention center and then go up an escalator, go down to the basement, choose the room you want to enter, and then you'll see the faculty speaking, and it could be somewhat interesting. But when we've queried our folks, that is the audience of TCTMD, of which has more than 75,000 regular users, so these are Internet-savvy people that are on TCTMD, 99% of people do not feel that meetings are going to decrease, and only 1% of people wanted a virtual meeting experience. So what you said, in your introduction was very, very true. There is no replacing the immediacy, and the experience of seeing live cases, of networking and interacting with your colleagues, of hearing the science presented so you actually understand the nuances, listening to the discussions. Of course, for the young physicians who are presenting for the first or second time, but also for us senior physicians as well. We want to connect with people. And so I don't see meetings going away. I do think it's going to be an increasing challenge, though, again, about how to make them cost-effective, how to make them increasingly innovative to continue to appeal to people. And I do think that the multi-specialty concept is going to be increasingly challenged. So I think that meetings that focus, medicine and cardiology in general is getting so complex and so difficult that I do think people want to dive deeper if they're going to spend 3 to 5 days on something. So I'm interested in your thoughts actually as the chair of the American Heart Association, which is still one of the great meetings which has been able to maintain its multidisciplinary focus.
Yeah, you've hit on a key topic, which is that our view and what we hear from our attendees is that while they appreciate the multi-specialty aspect of things, they do enjoy the connectivity. They want the deep dive. They want the deep dive into their area. And so we've tried to answer that by providing both breadth with the different areas covered, but within any one area, let's say basic science, having a very, very deep set of offerings that allows people to really focus on what interests them. And then, like you and others, what we've tried to do is connect the meeting by tagging things in the program, by having search tools that people can figure out, well, if I'm interested in cancer and cardiovascular disease, what are the sessions that help me understand that? So I agree with you, Greg. I think people are they're looking for more when they come to the meeting, and you guys have also done this well. You have to, you can't say that we're going to program from 9 to 5. You've got to recognize people are coming from around the globe. They want to start at 6 a.m., and some of them who are in a different time zone don't want to end till 9, 10 at night. You've got to provide something for them throughout that period of time because they need it to be cost effective. They don't want to have downtime.
Right, and nobody is, we do hear sometimes the meeting is too long. We can't figure out how to run TCT for less than 5 days, and it does go from 7 in the morning to 10 at night. And we always tell people no one is forcing you to go to every minute and every hour of every session. And we do archive everything. So if there are things you missed, in fact, we archive them with, linked audio and video. So if there are things you missed, you can get them. But people still get frustrated, I think not at us, but just that there's so much to learn and so little time.
Yeah, even for us meeting planners who'd love to go to every single session that's been created, there's no way you can. And you're absolutely right. The archived edition of the meetings can be very powerful. Well, Greg, I want to thank you for joining me here today on the Heart.org Radio. We've had an interesting discussion around the past, present, and the future of medical meetings. My congratulations to you and your colleagues at CRF. You've done a terrific job with really helping introduce a lot of innovation into medical education, and we'll look forward to seeing what you're going to do next. Thank you, Greg.
Always great speaking with you, Bob. Thanks.